You heard it. We're recording. Okay, and with that being said, I am pleased to introduce Ms. Lynn Corte. She's the Dementia Care Program Policy Analyst, and she's going to take it over from here. So, Lynn, it's all yours.
Great. Thank you, Anthony. And thank you everyone for being here today. I know dementia is one of those topics that we all are faced with, whether it's in our personal lives or professional lives. Just happy to see all of you here willing to engage on this topic because it can be a sometimes difficult topic to broach. As Anthony said, I'm Lynn Cordy. I work with Aging and Long-Term Support Administration, and I am the Dementia Care Program and Policy Analyst. So I've been here for a lot of years, around 30 some years, doing planning and program development related to serving people who are living with dementia and their family caregivers. I do a lot of work with area agencies on aging and our own programs to help keep staff informed about dementia and to help in the development of resources and knowledge around dementia. But prior to being here at ALTA, I did work in a variety of settings, including adult day services, residential care, two different community hospitals, working as a dementia case manager and a consultant for families who were trying to help somebody who was living with dementia or challenges related to behaviors with dementia. Currently, one of my major roles is coordinating work of what is called our Washington State Plan to address Alzheimer's and other dementias. I don't know how many of you are familiar with that. We do have a state plan, and that is managed and guided by a group called the Dementia Action Collaborative. So I work to support the Dementia Action Collaborative in implementing that plan. And that group, the Dementia Action Collaborative, is a multi-sector governor-appointed group that works to guide, implement, and support the recommendations in the plan. So while most of my career and my current role centers on dementia care and best practice approaches, I'm not a medical provider. So I just want you to know that I will do my best to share what I know about best practices, about practical issues in helping people who are living with dementia. But like anyone here, I don't have all the answers, and I'm very open to learning with and from you all who are here today. So as Anthony mentioned, feel free to put any questions you have in the Q&A panel. We have some natural breaks in the presentation, so we might want to address them that way during the break. So feel free to put those in there and we will see what we can do. So again, thanks for being here. If we move to the next slide, let me just give you a little preview about what we're going to cover today, just so you know what's coming next. We're going to do a little review on dementia, what it looks like in Washington State in terms of numbers. We're going to review cognitive impairment and dementia along a spectrum. And then we're going to move into talking about some best practice approaches for helping people who are living with dementia. And then within that, throughout the presentation, you'll see little icons where you can reach into sort of toolkit. We have a variety of tools and resources that you might be able to use on a daily basis. So that's what we're hoping to cover. And as I said, I want to start with just a little bit of an overview on the next slide around what dementia looks like in terms of numbers in our state. So Washington has one of the higher life expectancies in the United States. So that's a good thing. We're healthy, people are living longer. But I think as a lot of you know, the older you get, there is an increasing risk of dementia. So if you look at on this slide, the sort of younger, older group, the 65 to 69, there might be like a 3% prevalence of dementia in that age group. But you go up through the decades and over that time, risk increases. So by the time you get to the 85 plus age group, 1 in 3, 33% of people are likely to have dementia. So that is not to say that it's inevitable as you get older, because people live to 90 and 100 without getting dementia, but there is an increased risk as you get older. So moving on to the next slide. What you see here is this idea, and look at the dark blue line on this graph. So this is broken down by those age groups, 65 to 69, 70 to 74. So what you'll notice is that we have this growing older adult population in general. The fastest growing sort of subgroup within that older adult group is that 85 plus group. So we have a lot more people who are aging into that older group, which is also at higher risk of dementia. So what you're going to see over the next couple decades or so is this increasing number of people who are living with dementia. So while we currently have around 126,000 ish people who are living with dementia in Washington. When you look at 2040, we're going to have more than double that, like 270,000. So all of you out there, when you're thinking about finding services, we know we struggle now. We struggle to find physicians. We struggle to find in-home care, residential placements. When you think of the growth of the population we're going to have, we need to be considering what are the ways that we can best serve this population. How can we help people be healthier longer? Can we reduce the risks of dementia? Can we help people to stay at home longer? Those are all the kind of things that our Washington State Plan is looking at to address. And so I'm just really happy to be here with a group of people today who I know are committed to helping people who are out there living with things like dementia or other chronic conditions, and thinking about all the ways that we can help people live with dementia. So let's go to the next slide, because I think, as most of you know, it's not just the person living with dementia, those 126,000-ish people with dementia. It doesn't impact just that person, it impacts the whole family. Now, my guess is if I were to ask you to raise your hands around the room, how many of you have somebody in your family or a friend living with dementia, it would be pretty high, because in any group where I am, there are a lot of people who have had this lived experience of a grandparent, a parent, somebody they know living with dementia, right? And if you're in that group, you know that dementia is affecting everybody in their little constellation of people. So in Washington State alone, we estimate there are around 247,000 unpaid families. So those are people, you're helping your parent, you're helping your spouse, somebody who's living with dementia, sort of unpaid family caregivers. So about 247,000 people who are helping others. And we know that family caregivers are really the backbone of long-term care, right? They provide 80% of the long-term care in this country. So we need family caregivers when they're available to be helping people who are living with dementia. But it's challenging. So think of the role that those family caregivers are playing. They provide, if you look at national statistics, each situation's different, but nationally, about on average 26 hours a week of care. And it's the kind of care that goes on for a long time. We'll talk about that a little bit in a moment. And the care tasks they provide range from helping with things like finances, medication, transportation, to things that are very personal in nature, things like showering, bathing, managing incontinence, as well as managing certain behaviors that might arise. So, a recent survey also found that 70% of caregivers found that just the task of coordinating care is stressful. So things like coordinating with multiple doctors, scheduling help with appointments, finding supports and services, and simply feeling unprepared in their role as a caregiver. Those things are particularly stressful on top of the other things that they're doing. So as a system, we need to be paying attention to these family caregivers, and we're going to be talking about that more during this talk. So another thing that's important to know about our population here of people living with dementia in Washington is that there are health disparities. So national statistics indicate that older Blacks and African Americans are twice as likely twice as likely as older whites to have Alzheimer's or other dementias. And Hispanic Latinos are about 1.5 times as likely to have dementia. So we did a recent study when we were updating our state plan for Alzheimer's and dementia. We had our DSHS Research and Data Analysis Division look at what we knew about people living with dementia here in Washington. And looking at Washington State Medicare beneficiaries, had a whole data set, we found that Blacks and African Americans and American Indian Alaska Natives in Washington have higher rates of dementia diagnoses. So the prevalence of dementia for Blacks and African Americans was 46% higher, and for American Indian and Alaska Natives was 45% higher as compared to non-Hispanic whites. So in that same data set, it shows that Hispanic Latinos have a 2% higher prevalence for dementia as compared to non-Hispanic whites. So that data set, any data set you use, we're not sure how accurate any of them are. But it does show that there are some disparities and things that we are paying attention to within our state plan. So I want to move on from here just because that's sort of setting the stage for why this is such a big concern. So when we think of, the whole range of cognitive impairment. I want to sort of address just cognitive aging in general, and I just want to get us all on the same page, which is where does that spectrum become problematic, right? So if you go to the next slide, what I want us to consider is that there is the sort of typical aging, right? So like other organs of the human body, the brain changes as we get older. So the physical structures in the brain change and its ability to carry out various functions tend to decline. So while wisdom and expertise can increase with age, the speed of processing information, making decisions, remembering certain little details might decline. And this process is known as cognitive aging. So it's a decline in memory or decision making or speed. You know, you might be able to not remember a certain details of a recipe you used to know, or certain words, or you have trouble coming up with, you know, the name of somebody that you haven't seen, especially if they're out of context. So these are all things that are considered a normal part of aging. And that's different for different people, and it can vary from day to day. Then there's something called mild cognitive impairment. So mild cognitive impairment is a condition in which people have more memory or thinking problems than might be normal for their age, but their symptoms aren't severe enough to interfere with their daily life. They can still do things. It might take a little longer. They might need to use more reminders. You know, so that might be things like, you know, forgetting important information that you might have previously been really good at remembering. So remembering appointments, certain person's birthdays, recent events, or the ability to judge the time and the sequence of steps. My 90-year-old mother had mild cognitive impairment, and she just couldn't fathom she was going to be moving, and she just could not put all the steps together to what do I need to pack? How can I get everything organized for a move? Those kind of sort of more complicated things become more difficult. So a person with mild cognitive impairment is at increased risk of developing Alzheimer's or another dementia. In some cases, though, the condition might be caused by external factors, not real brain changes, but external factors like medications, say vitamin B12 deficiency, other nutritional deficiencies, thyroid issues, depression. So in those cases, that kind of mild cognitive impairment could be reversed. Sometimes it can't, but sometimes it can. So we're going to talk a little bit more about that. So let's go to the next slide. So then when you look at the spectrum, you know, you have cognitive aging, mild cognitive impairment, and then we look at the dementia issue. So dementia is a general term. So a lot of people, when we're presenting out in the public, and, you know, some of you may have gotten this question, what's the difference between Alzheimer's and dementia? Well, dementia is the general term for a decline in cognition that's severe enough to interfere with daily life. So activities of daily living. So dementia isn't a specific disease, it's an overall term. And that describes a wide range of symptoms that are associated with that cognitive decline, so memory or thinking skills. So dementia is caused by damage to brain cells from a disease such as Alzheimer's disease or Lewy body dementia. Or the brain damage might be caused from trauma, such as brain injury or stroke. So you see that up on the screen here. You see a healthy brain on the left. It's filled out, you know, there's not a lot of gaps. And then you look at an Alzheimer's brain, and there are literal gaps. There are changes in the brain. And I have found this sort of image can be useful for some families who don't understand that the person actually has changes, because on the external, they look like they used to. But there is damage to the brain that is actually affecting the way this person can move through the world. So when you see that kind of damage and you look at that sort of brain image, the brain cells can't communicate normally, right? So those are the things that govern thinking and behavior and even feelings. Those things will be affected because the brain is not, the neurons aren't connecting, the brain isn't operating the way it should to do the things we could do before that brain damage occurred. So when these changes become severe enough to interfere with daily life, again, there's a spectrum, you know, in the early stages or in that sort of mild, just cognitive aging or mild cognitive impairment, it's not going to affect their daily life. People can compensate. But once they're having trouble doing the daily skills, that's when it would be considered dementia. And again, it's not normal aging, and it's not inevitable as we get older. There are a lot of people who live to their 90s or into 100 without having dementia. So next slide. So clinically, to be considered dementia, not only does the impairment need to be severe enough to interfere with daily life, but also that there are changes in one or more functions of the brain. So you see those cognitive functions up on the brain. So memory, that's the one a lot of us think about. It might not always be the first though, and we're going to talk about that in a moment. So memory might be impaired, communication and language. So that's the ability for us to communicate out, but also to understand what people are saying. So also the ability to focus and to pay attention. That is a cognitive skill, and it is affected by the way our brain is operating, whether we can focus on something, pay attention to it. And then the ability to sort of use the things that we see, the things that we hear, for reasoning and judgment. So for reasoning and judgment, you have to be able to remember certain things. You have to be able to put things together to focus on the issue at hand. So reasoning and judgment is also a skill that might be impacted. And then visual perception. And I'm not talking about just older eyes having cataracts or macular degeneration. We're talking about the ability of the brain to understand and interpret what it sees. So these are all cognitive functions. So in a dementia, one or more of those things is going to be affected. So these changes from the brain, when you think about those things put together, are going to impact what people can do in their functioning, their instrumental activities of daily living, their activities of daily living, and it can lead to behavioral symptoms, which we're going to talk about how that sort of intersects. So if you look at this graphic and you see that general term, Anthony, can you, yeah, stick on this one more moment, because I just wanted to point out, when you look at that general term of dementia, that's the sort of umbrella term. And then underneath that, you have the different types of dementia, such as Alzheimer's disease, vascular dementia, all those different types, which we're going to talk about. So I just want everybody to be clear. There's the general term, and then there's the different types of dementia that are under that general term. Okay, now let's go to the next slide. Thanks, Anthony. So on this, what you see are some different types of the more common dementias. Okay, so you guys have pretty much all mostly heard about Alzheimer's disease. And Alzheimer's disease is the most common. It's the one we hear about. So, one of the things that we do know about Alzheimer's is that the risk for Alzheimer's increases with age. So the older you are, the greater the risk for Alzheimer's. But it can strike people who are younger. And when that happens, so if it happens under the age of 65, it's referred to as young onset or younger onset Alzheimer's disease. So this can strike people even in their 40s or so. Then we move on to vascular dementia, is another one that you might see a lot in your caseloads. And the symptoms with vascular dementia can vary a little bit depending on the part of the brain where the blood flow has been impaired. So symptoms often overlap with different types of dementia, such as Alzheimer's disease. But unlike Alzheimer's disease, the most significant symptoms of vascular dementia, particularly early on, tend to be things like the speed of thinking and problem solving rather than memory loss. So memory loss might not be the key indicator when there's vascular dementia. It tends to be seen in sort of a cluster with people who also have things like heart conditions or stroke, because when you think about that, the blood flow to the brain has been compromised. So what is also pretty common, and they're finding more and more in research these days, is that there is a mixed dementia. So people might have Alzheimer's and vascular dementia, or a different type of dementia. So then the third one I wanted to talk about is dementia with Lewy bodies. And this is one that when I first started working in this career, this was not even mentioned. And they've learned more and more about dementia with Lewy bodies. And this can look a little bit different. So you might see somebody with those, they look a little bit that Parkinsonianism, the sort of flat affect or the rigidity. So it looks a little bit different. And the thing about dementia with Lewy bodies is that the symptoms early on are very different. So one of the key indicators with dementia with Lewy bodies is they have really vivid visual hallucinations early on, and their cognition can fluctuate. So if you talk to somebody who's had this, they might be really doing well one day, and then another day they might just be really bad cognitive function. So it can sort of fluctuate a little bit more. So it's important to know about dementia with Lewy bodies, and because dementia with Lewy bodies is one of those ones where if people are given the medications like antipsychotics, they can have a really severe reaction. So what's come out in the research is this importance to identify if it is dementia with Lewy bodies, not just labeling it as dementia. It's important to know that because there can be different ways to treat and manage that. So the fourth type that I wanted to mention is frontotemporal dementia. And the reason I want to mention this, it's not quite as common as some of the others. You might hear of it as Pick's disease. You might have heard of that, but there are other different types. It tends to develop at a younger age. So often in the 50s or the 60s, but it could be even younger, sort of like the young onset Alzheimer's disease. And the early symptoms tend to be personality or behavior changes. So it might be apathy, pretty significant mood swings. I had a couple clients and in these families, in the situations where people had frontotemporal dementia, in both the cases, there were couples and people with even small children, and they had gotten divorced. So had real, relationship personality changes, lost their jobs. Years later, they find out that it was a frontotemporal dementia. At the time when I had these cases, people weren't diagnosing that as quickly. And, it still might be problematic today. So it can happen to people who are younger and people don't suspect some type of dementia. There's just these personality changes where people really can't function. And then they find out through a series of testing that it might be frontotemporal dementia. So keeping in mind, when we're talking about dementia, we always think of older adults, but both younger onset Alzheimer's, frontotemporal dementia, they can be in the younger population, and those families typically have a really hard time getting a diagnosis. So talking about diagnosis, I do want to mention that most dementias can be diagnosed by a primary care physician. And I think we always think we have to go to a specialist, and most people want to. And I think when you have access to it, that can be wonderful. The kind of cases where you really want to refer somebody to a specialist is if you're seeing those different things like dementia with Lewy bodies, frontotemporal dementia, those younger ages, where you might want a specialist to look at it because it's a little harder to pick apart, right? The sort of looking at what it might be. So if it is a typical Alzheimer's vascular dementia, primary care can be pretty good at diagnosing those. And we've been doing a lot of work through our state plan to better prepare primary care physicians, providing a lot of opportunities. How do you detect it? How do you make the diagnosis? What kind of tests do you need? And then how do you support people once you've done that? So that is something we've been doing a lot of work on through our state plan. Okay, so if you go to the next slide, I do want to talk just a little bit about the progression of Alzheimer's because it is the most common and often mixed with other types. And I know you guys see this, you probably know this. I'm just going to review it a little bit just so that we can get our heads around this fact that Alzheimer's disease can go on for a long time. So the average duration is around 8 years after diagnosis, but it can go from 4 to 20 years. I've worked with a lot of families who were dealing with this over a really long period. And that has impacts for the person and for the family. So in those early stages, it really is, minor sort of memory issues, concentrating, finding the right words, misplacing things. You guys know that constellation. Then you get to these middle stages, and that's where the memory and the thinking are getting bad enough that they're struggling with things. And they're struggling a little bit with communication, not understanding things, perhaps, or you think you're being clear with them, but they're not understanding, or they're trying to tell you something and that's not clear. It is also the point where communication struggles end up leading to some behavioral issues because they need to start using behaviors as a way to communicate. So we're going to talk about that a little bit more. And right at this point, in this middle stage, they're starting to have trouble with their activities of daily living. So in the first stages, those early stages, they might have a little more trouble with those instrumental activities of daily living. So that might be things like managing their finances, taking care of some of the things they need to around the house. But in the middle stage, it starts to become the activities of daily living. They can usually function with reminders, and some people, if, they can have something that they've done all their life as a routine, they still manage pretty well if they're still in the same setting, have a lot of routines. But then when you move into the later stages, they have enough functional decline that even those become difficult. And somebody actually has to either remind or help with those activities of daily living. They have more trouble having a conversation. They'll start with having bladder incontinence and then move into bowel incontinence, and then in the very later stages have issues with swallowing. So that's sort of the major progression, but to know that it depends on the person. It can be different from person to person. Over time, it can be different depending on which type of dementia they have or the other types of health issues that they're dealing with. So that's just a quick overview. And what I want to end this little section with is this need to challenge the existing narrative around dementia. And that is what one of the things in our Washington state plan is about. So if we could go to, yeah, there we go. Thank you, Anthony. In this section, what I just want to talk about is that, the prevailing view, I think, of Alzheimer's or any dementia is sort of that late stage. That's the image people hold in their head. It really tells this story of loss of identity, the loss of their dignity, and the loss of ability, almost a loss of personhood. So, this kind of narrative really leads to sort of fear, shame, and social isolation for that person and for their families, right? So it really prevents people from pursuing an early diagnosis. This is one of the things around this whole issue of getting diagnosed is that people just, what's the benefit? There's such a negative view of this. So what's sad about that is the things that we can do and the things that we can help with, we have more time to do that if we diagnose people early. But this negative narrative that we have prevents people from wanting to get a diagnosis, getting that diagnosis, and it prevents people from getting the support and the preparation they need over the course of the condition. So it also prevents, doctors, physicians, healthcare providers from talking about memory loss with their patients because some people don't want to even bring it up. So we're going to talk a little bit more about this sort of narrative and the various ways that we're trying to support and have resources to work on this. So we do want to flip to the next section, but before that, are there any questions that have come up in the Q&A, Carrie?
Oh, there's one question for you, Lynn. What could be the problems within the Black community?
Can you say a little more? Are you meaning like why people might be at higher risk? Is that the question, or are you asking about what the problems after they get dementia?
That's how the question was put in the chat.
Okay.
I'm assuming that, yep, Maria says yes.
Okay. So yes, I mean, that has been researched a lot, Maria, and thank you for asking that question because there has been a lot of work on the issue of disparities and dementia and something that we are all very interested in. And what we do know is that there are, while we can't prevent dementia, we have found that there are modifiable risk factors for dementia. And some of those are more prevalent in the Black and African American communities. For example, if you have untreated hypertension, if you have diabetes, those types of things, certain chronic conditions increase your risk of getting dementia. They are more prevalent in the Black and African American community. So that's not to say that's the only reason. There are a lot of things around just access to services. We know that people in the Black and African American community get diagnosed later, for example. Now, is that an issue? Those could be issues of structural institutional racism, discrimination, poverty, stress, all the issues combined that are social determinants of health and chronic conditions that do increase people's risk for dementia. So that's one of the reasons in our plan, you'll see a huge emphasis in our state on addressing some of those issues within communities that are higher risk, Black and African American and Latino communities. So does that answer your question, Maria, or is there something else under that?
Well, Annie's asking a question along with that. She's asking, are diet and exercise factors?
Yes. I would, when you look at what's really interesting is when you look at brain health, and a lot of materials have come out or research around brain health lately. And a lot of the things that you see about, there is a link, number one, let me just say, they have found there's a link between heart disease and brain conditions, right? So when you look at all those things that are good for your heart, things that are good for your heart are good for your brain. And what we found that's good for your heart are diet and exercise, basically a healthy, Mediterranean or other diet that is sort of really well balanced and focused on fruits and vegetables and exercise, physical activity, staying active. There are also risks, smoking, obesity, things that are linked, somehow with the whole just healthy body idea, healthy heart, healthy body, healthy heart, healthy brain. So exercise and nutrition are vitally important. And I didn't cover brain health in this talk because I just didn't really have time, but brain health is a really important issue, and we're going to be putting out a lot more information. We're working on that through our state plan. And so I would encourage you, if you want to reach out to me afterwards, I'd be happy to send you some materials on brain health. My email is at the end of this presentation. But I just would say to all of that is this whole idea that if we can keep people healthier throughout the lifespan, all those things that we know about chronic conditions, staying active, eating healthy, not drinking too much alcohol, not smoking, those things all keep our bodies healthier, our hearts healthier, and our brains healthier.
And on that note, Lynn, John's asking, what is the impact of alcohol on heart and brain health?
Oh, that's such a good question. And I wish I were a really savvy medical provider who could answer the exact thing. And I probably can't. But what I do know is with the, excess alcohol, I think you guys probably see people with alcohol related dementia in your caseload, I would think. People who drink too much alcohol, it's not good for your brain. The hard thing to pick apart there is that a lot of people who are drinking excess alcohol are doing other things that might also be unhealthy. They might be smoking, they might not be eating right, they might not be exercising. So it's really hard to pick all that apart. And I can't answer the sort of, difference between what causes what. But we do know that, I've seen studies, for example, that say 1 glass of wine is a good idea, but excess alcohol is not a good idea. So again, I'm not saying any one answer is out there, but the more you read about healthy aging, excess alcohol, smoking, those kind of anything like that are going to be bad for your heart, for your body in general, and for your brain. So again, if anybody's particularly interested in this area of brain health, feel free to email me afterwards and I'll send you some of the things that I do have about that. Okay, should we move on? Is that it for that section? Great.
No more questions so
Thank
far.
you guys for that question. That really points out to me I should have had brain health in here. And, I have a whole presentations on brain health, but it could take another hour or two. So thank you for asking those questions and being concerned, because quite honestly, I think that is the thing we need to be doing as individuals, as family members, and as a state, is really promoting health in general over the lifespan. So now we are going to move to some of the practical best practice approaches. So I'm going to be talking about 5 key approaches that you see up on the screen. And these are all focused on the things we can do to help people with dementia. So what specifically can you do in your role? So you all are really in a great position to help. So you can better support people with memory loss in a lot of different ways. So you can help people who might have signs and symptoms of dementia understand why talking to talking to their physician or provider about memory loss is important. We're going to talk about that a little bit more. But a lot of people don't want to get a diagnosis, right? Or are resisting getting a diagnosis. So you can help them with a conversation about that, and we'll give you some tools for that. You can also help people maintain optimal health, which is just what we were talking about, is if people can maintain optimal health and mood, this alone can help functioning. This is sort of leading up to dementia. If you have mild cognitive impairment, if you already have dementia, helping them stay healthy and in a better mood can improve function. I used to think about it when I was doing adult day services, keep people happy and healthy and they will function better. So if that's sort of just a simple way to sort of think about that. You can also help them to minimize negative outcomes. So these would be things like falls, preventable hospitalizations. Those things can make it harder for people who are living with dementia to do the things that they can do, right? So if you can do those 3 things, those alone can help people be better and stay at home longer. Another thing that we can do is help family members. And really by helping the family members that are involved and that are, supportive in the process, if we can help those family members, we can try to help keep them healthy, keep them informed on how to manage. We will all be better off because if there is somebody who can do those things in the home, that is better for the person with dementia. Typically, we all know of situations where a family dynamic is negative and we don't want that around. But when there is somebody involved and we can support them, it is better for the person to be in a familiar setting where their routines are known and they're comfortable with that setting. So what you notice about these 5 approaches is that in the middle is the person with dementia and the family caregiver. And we do look at those together when they are present and when it's possible, because we think of them as a dyad. So if you can help, you might not be helping that person with dementia because we can't cure the disease, but we can help the family caregiver to help them and to stay as independent and at home for as long as possible. So we'll be going through each of these 5 key approaches. So the first is early identification diagnosis, dementia impacting all other needs, including including and supporting family care partners, medication management, and building independence and safety. So those are the things that we're going to be going through for the rest of our time here today. So we've already discussed the spectrum of cognitive impairment, and I'm going to invite you, Anthony, if you want to go ahead and queue up. I want to introduce, while you're queuing up that video, I want to introduce this. So in this topic, I just want to share, that we've already talked about this spectrum of cognitive impairment, right? So cognitive aging, mild cognitive impairment, and dementia. And you guys might be working with people at any of these stages, right? So, you think of that group of people who are worried, right? They're worried they have something, but they don't want to do something about it. It might not be diagnosed yet. And I'm sure you have people like that. So it's really important to be recognizing this situation, because when people are diagnosed early and we can help them get there, there's a longer runway, more opportunities to make an impact. So it might be an impact on their health down the road. It might be an impact on their function, their quality of life, or just on the ability of a family caregiver to help the person at home. So there also could be an impact on costs, right? Because putting somebody in a setting such as memory care setting is very expensive. It's expensive to an individual family. It's expensive to the state. So we're going to start out. So hearing from a person with lived experience, his experience with getting an early diagnosis. So in this video, you're going to meet a man called Bob Wellington and his wife, Anita, and they're talking about their experience. So I happened to meet Bob after he had been diagnosed about 4 years earlier. And then when we formed the Dementia Action Collaborative, he became a member, a representative of the Dementia Action Collaborative. And so after we had known him another 3 years, I decided we really need to interview him and get some of his impressions of his lived experience. So that's what this video is about. So as you're watching, when Anthony cues it up, I want you to listen for a couple things. One is there anything in this video that surprises you? Is there anything that you learn that's new or different? Feel free to just throw it. I don't know, we're using the Q&A. Just feel free to throw it in there. I just am interested, or in the chat. I don't know how you do that when you're just throwing out comments. But I'm interested to know what you guys take away from this. Thank you, Anthony. We're not hearing anything, Anthony.
I'm sorry, are you not able to hear it? I was asking if people could hear.
I'm not able to hear it. Is anybody else able to hear it?
Nope.
Okay, sorry about that. Let me get this situated. I apologize.
That's okay. This happens very often.
Yep.
It can be right 1 minute and then poof.
Yep, have it set up, and then the next thing you know,
Yeah,
bam, in your
yeah.
face.
Those little gremlins are out there.
Oh, then they do it too. Okay. Let's see here. Okay. Share screen. Full screen.
Yeah, you may need to go back to a little bit on the beginning to get
Yeah.
that set.
Absolutely. So here, let's do this. Uh, okay, I think we're good. Let me try again. And you all tell me if you can hear now.
You should be hearing music, so I think maybe not.
Still can't hear?
Nope.
Nope.
Well, barbecue my chitlins and hog gravy. Oh my gosh, I had this figured out. I promise I did. Let me,
I know, I'm sure you did. It's those gremlins at work.
um,
There's also a full moon the other night, so who
oh
knows?
boy, don't do that. Okay, let's try one more time. And I think this is, if not, I strike out, I go to the dugout.
Okay,
That's a
go.
shame.
There you go. Perfect.
Man,
I was born in Portland and raised in the Pacific Northwest.
My husband was diagnosed with early stage Alzheimer's little over 8 years ago. And we kind of knew something was happening. And it comes on gradually. He would have an episode of something strange, like driving past a road closed sign and not seeing it.
The straw that actually broke the camel's back was what we call the kitchen cabinet incident.
One morning I walked into the kitchen and saw Bob pulling on the side of the kitchen cabinet. And I stood and watched him for a few minutes, and he just kept pulling on the same side. And I said, "What are you doing?" And he said, "Well, it won't open."
And finally she tells me, well, why don't you should open the other side. So I reach around and of course the cabinet door opens.
My stomach just turned over, and I thought, this is not lack of focus. This is cognitively something very different. So I went back, and that's when we started the process of the testing and so on, and found out that he was diagnosed with early stage Alzheimer's.
The sooner one finds out whether or not they have cognitive issues, the sooner they can get started on an active program to help themselves.
Bob quickly got on medication. He exercised. He started eating right. We started working on all the things that could help Alzheimer's progress more slowly. But I also think it's important to talk to each other about how you want to proceed and how you want things to happen in the future, because the guilt can be both ways. You know, if I have to make decisions for my partner later on, that he's at some point not going to remember that we talked about it, but I know we talked about it. He said he wanted this and he wanted it to be done this way, then I won't feel guilty when I have to do that because he won't remember it. So we should discuss the future while everybody's alert.
Juanita and I, of course, started working on paperwork, changing some of our insurance and our other legal paperwork that we have to make sure that our finances were properly set in order, wills, powers of attorney, making some minor changes there. And I, of course, strongly recommend this to anybody out there.
The quicker you act, the better time you're going to have. You can plan, you can organize your life.
Since then, Juanita and I have tried to do as much traveling as we can. We both love to travel. We've been fortunate in being able to do that, even with the dementia. We find ourselves at this point in our life with no regrets.
Thank you, Anthony, for getting that to work. Appreciate it. I know it's stressful in the moment when that happens. So thanks for sticking with it. All right. Feel free to throw in the chat. This isn't really a question, but feel free to throw in the chat. Is there anything that surprised you? Anything that you learned that's a little bit different through that video? let me ask one thing. It wasn't just his memory loss that was the sort of straw that made them think something else was wrong. Do any of you remember what did they say was the turning point where they thought something was clearly wrong? Yes, exactly. The cupboard door incident. And I bring that up because to me, when I heard him speak, I heard him speak at something when he was like 4 years into his diagnosis. And I thought it was really interesting because it's a great reminder to us. It's not always just that memory loss. It's that sort of visuospatial, just doing something you could have done just easily before and you couldn't do it in that moment. So watching for those kind of things where something is clearly different. And yes, and thank you. Somebody said drove past a sign on the road. That was unusual, right? And his wife noticed for him that was really unusual, right? So those kind of things, it's not always just the memory loss, but a change from where that person was sort of cognitively. That's really important. Is there anything else that surprised you or that you learned from this couple? I mean, one of the things, so much planning would go into so much into the planning. Yes, thank you, Alyssa. They were a very planful couple, and that is sort of when I sort of got to know them, I just thought, they were working together. They were working together as a team. They were willing to face it, right? And I know people aren't always willing to face it, but they were the type that said, "Oh, we might be able to do something. Let's seek out and figure out if there is anything we can do." Um, a measure of peace. Yeah, not everyone is as open to treatment. That is absolutely true, Emily. I think, a lot of it is personality and the way people have addressed other health conditions or other problems in their past. But they did get to a point of acceptance. And, when you actually, there have been surveys done that a lot of people have a sense of relief once they get diagnosed because they know something's wrong. So whether you diagnose it or not, it can progress, right? There's another video in this series, if you ended up going into it, and the woman says, "What's the harm in finding out? If you have it, it's going to progress, right?" So she would rather have known about it and done what she could about it because if it was really there, it was going to progress. So facing it does allow them to do something together. Yes, and thank you, Elma, for mentioning that they could do and problem solve it together. So I know they're a picture of how we would all want it to be. It isn't always this way, but I think it is a good lived experience for thinking through what it can do for some people if they go ahead and get their diagnosis. Thank you all for your thoughts. Okay, so let's move on to the next slide, where we are addressing this issue of early identification, so that one of the best practices thinking about this as something that is important to be thinking about. Not everyone's going to be like Bob and Juanita. We know many people are hesitant to talk about it. In fact, we know we have surveys, the Behavioral Risk Factor Surveillance Survey, which is done every year in Washington State. We ask people, has your memory gotten a lot worse in the last 6 months? And if people say yes, they're asked, have you talked to your physician about it? What we know is that less than half the people who have some change have talked to their physician about it. So there's a lot of reasons why, right? And it's different for each person. Sometimes it's just a lack of understanding, what's normal, what's not. They think, oh, it's just aging. And there's also a stigma around it. People think, believe, and probably know they're going to be treated differently, right? So there is this sort of lingering stigma that keeps people from getting a diagnosis. And there's this feeling for a lot of people, why should I bother? There's nothing I can do about it anyway. But one of the things we're doing through our state plan is trying to counteract that thinking, because there are things we can do at any stage along the way to make their life a little bit easier and potentially to impact the way it progresses and the experiences as it progresses. So Bob and Juanita mentioned some of the benefits, but to add to these, I just do want to say it's really important for the symptoms to be looked at early because it might be something that's reversible. In some cases, as we said, it might not be the brain damage. There might be a medication issue, a vitamin deficiency, clinical depression. There are issues that can cause, cognitive issues that sometimes can be reversed, sometimes they can't. but some of them can be. Secondly, early detection of dementia means that we can recognize when supports needed to be in place to manage other things that are going on. It's really important to know, that if you have dementia, it's going to impact other stuff that you're trying to take care of. We'll talk about that more in a moment. And third, knowing if a person or a family is dealing with dementia, whether it's diagnosed or not. So this is the important thing, diagnosed or not, because some people never go through that process. It helps us think through what kind of referrals we could make to support this family as it progresses. So this might be, around medications to treat the symptoms, education to learn about and deal with their own legal and financial planning, as Bob had mentioned, or services to get more educated about what's ahead and gathering information so that you're prepared for what is ahead of you on that what could be a very long road. So early detection serves as a gateway to other supportive interventions that can positively impact their quality of life. So thinking of it that way, I know it's a hard conversation to have with people. And so on the next slide, if we move to that, please, Anthony, thank you. This is a resource, and I would encourage you to look at this yourself because it gives you words to have this conversation sometimes. It's also a resource you can share with people that they might want to look at themselves. It's all about living well with mild cognitive impairment or dementia. And it talks about just some of the basics about establishing yourself a routine, staying active, managing your health, a lot of the things that Bob had said, trying to reduce the stress in your life, finding meaning and purpose, and continuing to live with dementia. Because then you could see Bob was 8 years into the diagnosis there. We had another woman who was diagnosed on our at Action Collaborative at the same time Bob was, and she was similar. You can look at another video of hers if you go to our Dementia Action Collaborative site, and she was still living alone at 8 years. And she had done a lot of things to take care of herself as well. So, giving people a little bit of hope that you can live well with dementia. And, again, every person's different. You're not going to just, if you do these things, be in their same situation. But there is some hope and empowerment that we can provide for people for living well with dementia. So I encourage us to take the opportunities we can to share those kind of things with people. So thank you. That's my soapbox that I like to be on because I've just been working with enough people with dementia to know that, there is life after a diagnosis. And while it can be a different experience for different people, we can do what we can to help the people that we can help. So if we move to the next slide, I want to talk about this next best practice, which is dementia impacting all the other needs that they have. So this is a concept, and this actually came out of Dr. Sue Borson used to work at the University of Washington. She's moved on to become a national expert in how do we best care for people who are living with dementia. And she calls it dementia as the organizing principle on which any care plan should be based. Because dementia is going to impact all the aspects of care, whether it's treatment planning or the long-term outcomes for any other co-occurring condition. So considering dementia as the organizing principle of our dementia care plan means that we're going to recognize that people with dementia have a number of concerns. They might be healthcare concerns, they might be socioeconomic concerns, and all those other concerns are likely to be impacted by the dementia in some way. So it affects the way we might address those concerns, right? It also recognizes that as the disease progresses, individuals with dementia, because of its progressive nature, will be less able to fully participate in their own care, monitoring their conditions, maybe following medication protocols. So not only are we looking at dementia as a way to think about meeting the needs, but we're knowing it's going to change over time and we need to keep rethinking about it. So once we're aware of their declining condition, whether it's diagnosed or not, because we can encourage people to get a diagnosis and some will and some won't, right? We should be using this as a way to think about the kind of supports that we're putting in there and acknowledge it as much as we can and they're willing to accept, right? So as an example of this, let's say you have a person who's living alone and you think, okay, well, maybe we could get him Meals on Wheels and that would help, help his nutrition. So do we know that person, that he might understand and remember what to do with those meals when they arrive, that he needs to refrigerate them if he's not going to eat them right away? Do they know how to open the container? Do they know how to open the microwave safety? There was a whole grant that I saw in another state where they had people going in and finding these meals just piled up, not even in the refrigerator or some in the refrigerator. And it turned out the person didn't know how to operate the microwave. So, you have to think through all those meals. Is what I'm putting into effect or trying to put into effect going to be possible for that person based on their cognition, what they can do? So we always need to be thinking about what can they do, not focusing on what they can't do, recognizing what they can't do, but thinking about what they can do and how can we keep supporting that. And that will help us keep a more cohesive and responsive type of care plan. So we're going to look at an example in the next slide. And I'm going to read this off to you, and then I want you to be thinking and putting into the chat, not the Q&A, but the chat. So thinking about this case. So this is a case of Mrs. K, who's 82 and lives at home with her husband. She has diagnoses of hypertension, cognitive or congestive heart failure, and dementia. She's doing less and less around the home and appears a bit disheveled and unsure of the answers when you're talking with her, sort of looking to her husband, sort of the typical looking to her husband to answer all the responses. So Mr. K is there present, and he doesn't want to leave her alone for long. He wants to keep her at home. He's probably one of those caregivers who says, I'm promising not to put you in a nursing home. He's 84 himself, and while somewhat frail, he's working hard to keep things going at home. He prepares the meals and drives them to their doctor's appointments. He encourages his wife to do as much as possible for herself, such as managing her own medications for the conditions mentioned above, and doing other tasks for herself, like dressing and bathing. So if you came upon this case and you notice that she's been hospitalized twice in the last 6 months, I just want you to think about, if you were presented with that, what might you see or hypothesize was going on with those hospitalizations? What kind of things might have been happening? Do you have any ideas? Yes, concerned about managing meds, missing meds. She may not be taking them because she's doing her meds herself. That might, yes, you guys keyed in on a very key factor. And yes, John, there might have been falls. We don't know right off, but there could have been falls, and the falls could have been related to a number of different things. Could have been dehydration. Yep. Great. Those are some great thoughts. So I think what you need to be thinking of when you come across a case of a person with dementia is putting it in context of all the other things that they have going, the things they can do and maybe not do for themselves. So if we move on into the next slide, thank you, Anthony. Let's talk a little bit about chronic conditions in people with dementia and what we do know. So what we know from data is that 77%, 3/4, are going to have 3 or more chronic conditions in addition to the dementia. Okay, so that means that they have a lot of stuff going on that's not just the dementia that needs to be managed. At the same time, they have cognitive impairment, which is going to impact the way they're going to manage those conditions. 95%. So almost all of them have one other chronic condition, which might be something like diabetes or hypertension, COPD, anything, congestive heart failure, a lot of different things could be going on. So thinking about those facts, if we go to the next slide, what you'll notice is some statistics that I think are pretty enlightening. More than half of people who have dementia also have hypertension. Close to half has some sort of heart disease, chronic kidney disease. A significant portion, 37%, have diabetes, congestive heart failure, and others will have COPD or stroke. So that's pretty telling to say that when we come across a person who has dementia, they're probably going to have other health concerns along with, just other concerns in their life, right? So we need to be thinking, how is the dementia impacting the way that they are managing those conditions? So if we move on to the next slide, we're going to notice what you guys noticed about maybe missing meds or having falls, is that people who have dementia are hospitalized 2 to 3 times as often as people without dementia. And In some of the research, when you look at utilization of potentially avoidable or preventable hospitalizations, people with dementia have greater odds of having those kind of hospitalizations for conditions like diabetes and heart disease or hypertension. People with dementia also do have more falls and more injuries due to falls. So knowing that those things sort of, come together, when we look at the next slide, we want to think about those hospitalizations because there are some real common, on this slide, what you're going to see is there are the ones that, you can't prevent, seizures, there's going to be some things that we cannot prevent, right? But there are some of them that we may be able to impact, right? So falls are common in people living with dementia. And once they've had one fall, they are more likely to have another fall, right? So thinking about that, people with dementia are actually 4 to 5 times more likely to fall than other older people of similar age who don't have cognitive impairment. And the risk of sustaining a fracture is 3 times higher than it is for cognitively well people. So why do they have more falls? When you think about it, and those things we talked about where the brain has damage, they don't have the judgment. They might not be able to think, oh, I should or shouldn't do that. They might not be quite as coordinated as they were in the past. We know their neurons are not connecting all. They might not see a risk out there. They might not interpret their environment because of that sort of visual perceptual changes that we talked about. I used to work in a nursing home and they had some tiles that went around the facility that were a dark black and the rest of the tiles were white. And the people with dementia, many of them would walk up and they would take this big step over the black because they thought that that was a hole or a trench. So they didn't quite know that that was just a tile. So they have more trouble seeing sort of the differences, recognizing what does that black line mean. So they might sort of take a leap over that, which could increase the risk of falls, right? Or people often, they might miss a toilet because they have a white toilet seat with white tiles and they don't quite sit on the toilet correctly, or they might fall off or miss. So, those types of changes in the brain can lead to issues where they might sort of fall more. They might fall off the toilet. They might, be stepping over something, around something. They might not see something like a cord or a throw rug and they might fall. So what could we do? We can't really change the dementia or that cognitive aspect of what they're experiencing, but we could work with a family member or with the person to reduce some of those risks for falls, right? So we might do that kind of simple home assessment where you make sure you don't have the throw rug, the cords, you have better lighting. You think about equipment that would make the bathroom safer, maybe an alternate colored toilet seat or grab bars around the toilet or grab bars in the shower if they might be, showering themselves and need some extra support. So to help, we could help reduce those risk of falls by asking for a home safety evaluation if you have a company in your area that does that. Or you could arrange for a visit from an occupational therapist who could do some home safety evaluation and make some suggestions around fall risk. But also consider something like those chronic conditions like hypertension. We learned earlier that people with hypertension and dementia have more preventable hospitalizations, right? So think about what could we do in that situation? Might we be able to work with a family member if they're there to make sure that their meds are managed more appropriately, or come up with those reminder systems you guys know about, coming up with something that would help them know how to take their medications. And we're going to talk about some of those sort of tips a little bit later. But thinking through the things we can prevent. We can't change the condition, but we can try to think about what are the other risks that are present that we could help to reduce. Okay, so let's move on to the third best practice. And that is including and supporting family caregivers. Now, I know I already sort of stated the reason why we need to do this. But when we're helping people with dementia, it is really critical to think about this role of unpaid family caregivers and not just as collateral contacts like we might in an assessment, they're giving us information, but think of them as part of the care team and part of the informal support network around this person. And when we think of family, of course, I think we're all on that same page, I hope, is that this is surrogate family. It's the family the way the person defines it. So it might be a neighbor, it might be a friend, it might be, some people in their church or other faith organization. So thinking of the people who are in their lives, As the disease progresses, people with dementia are going to be less able to successfully navigate their own care and their home itself, right? So in those early stages, so a care partner or a caregiver might take on some of the simpler tasks like, helping the person get to doctor's appointment, helping them maybe pay their bills. But once they are getting more progressed, they're going to lose their ability to sort of fully participate in their own health and medical care. So it becomes necessary for caregivers to start taking on more. And we talked earlier about they get to the point where they're doing like 26 hours on average. They're helping with more and more. They're helping, in terms of medical care, treatment, medical adherence if needed. On top of the things that they need help with at home, we think about trying to make good connections with medical care. Well, a person who's living with dementia and goes to a doctor appointment might not remember everything they need to tell the physician what they're struggling with. They're going to rely on the family member or somebody else to maybe come along to the appointment or at least call ahead of time to sort of report what are some of the things that we see happening with this person. Because a medical professional, I've just heard so many stories is that the person goes to the doctor and the doctor doesn't even know that certain problems exist because the person with dementia either doesn't have the awareness of them or the memory to report them at that doctor's appointment. So if there isn't somebody else in the room to help that physician really know what's going on, then the full picture doesn't get seen by the medical professional and they can't provide the kind of care that's needed. So the caregiver role is important in a number of ways. They can provide information, but they are also part of the support team in helping with some of the practical things around the home, linking with healthcare professionals, and being there to support sort of the whole organizing of that person, the person's needs and what they need to live safely and well. Okay, going to move on to the next slide. So many families, though, and you guys have probably come across this, they're not born caregivers. People who get thrust into the family caregiver role don't necessarily know how to provide care for somebody living with dementia. So, I have found that some people take sort of naturally to it and they can, go with the ups and downs of the person's cognition. Other people can't do that at all. But you can help family members very often help the person understand what's going on a little bit more, helping them to understand what the dementia is, help them in providing some of the tasks they're needing to help with, right? Whether it's IADLs or ADLs, you can help them get the skills and the knowledge that they need to do that, or build some awareness around the healthcare needs so that they can be helping the person better meet their healthcare needs. And you can help them by understanding what types of needs should be reported to a health professional, or what could the family member be doing, like going to the appointments with them, contacting them ahead of time, or just directly reporting to the health professionals what they are seeing as well. So families very often need to be empowered to do that or supported to do that. Sometimes they don't want to usurp the control from the person, but you might be in a position to help them understand the person can't get the best health care if the healthcare provider doesn't really know what's going on. So thinking about ways you can help the family caregiver to help that person who is living with dementia. So if you go to the next slide, we have some tools and resources that can help you do that. I don't know how many of you are familiar with the Dementia Roadmap. It's gotten pretty far and wide in Washington. The Dementia Roadmap looks at dementia from that point of worried and wondering. We don't even know if it's dementia yet. Here's what you can do. Mild cognitive impairment. Here's steps you can take, action steps. What to expect at each stage, early, mid, or late. And it literally walks through what kind of questions the family might have at that point. What can they be expecting at that point? What should they be doing at that point? And then what resources could help? If you are not familiar with the Dementia Roadmap, I strongly encourage you, and when you get these slides, to take a look at it. It is available online. It's available in Spanish and Russian, as well as English in print copies. And at our Dementia Action Collaborative site, which is there up on the screen, you can order, if you're going to be giving them to people for personal use, like a family caregiver, you can get 5 they basically comes to me. If you want to get a box of them, you go through our fulfillment center like any of our other kind of documents and forms, and you can get a bulk box for your office, say, for example. They're free. You do pay for shipping and handling when you get the bulk copies. So I would strongly encourage you. I've had case managers who have used this as a way to sort of talk through, here's where you are now. Here's some steps you could be taking. So it's useful to you as a person working with somebody with dementia, but it's useful for the family caregivers to give them. People have found it a very helpful document and helpful in promoting some of the action steps people need to take. And then the other resource on the right-hand side, I'm sure many of you know that people with Down syndrome have a very high risk of Alzheimer's later in their life. So dementia on top of the Downs. And there are some resources in this document around, it's sort of a handbook for families who have a person with Down syndrome who is moving into a dementia as well, and how some tips and strategies and supports. So these are both useful documents. I encourage you to take a look for your own edification and or to share with people that you work with. Okay, then we move on to the next slide. And you remember, Bob had talked about, and I have shared how, having this runway for support is important. I'm sure you guys see people who get into your care and they don't have really the ability to make decisions for themselves anymore, but they haven't named somebody, right? They haven't done their legal and financial planning paperwork. So it's really important that we all, as professionals working in this field, are helping people to understand, any adults understand the importance of having powers of attorney for healthcare, powers of attorney for finances, and advanced care directives. So if you come across people, for example, who have MCI, or they're in the very early stages of dementia, and you notice they haven't completed their legal planning, or I would say for any 60-year-old or older that you come across in your work who hasn't done their legal and financial planning, would encourage them to do that. None of us know at any point when we might have an accident, when we can't make our own decisions. So have we named do we have a healthcare directive? Have we named somebody who can make decisions for us in the case that we cannot? So if they haven't created some sort of powers of attorney, I would hope that we could all as professionals start imparting that need to do so, because we're seeing the impact on the other side when people do not have that paperwork in place and we don't have those directives. So one of the things we did as we were working with the Dementia Action Collaborative in the state plan, along with promoting early detection and diagnosis, is to say, if you're getting an early diagnosis and you haven't done your legal paperwork, do it as soon as you can. In those very early stages of dementia, you could still have the capacity to do that. Let's get that paperwork set into place. So we created this, it's called the Dementia Legal Planning Toolkit, and it goes through issues like capacity and planning. And it's a folder, you open it up, it provides a lot of information and resources where people can learn more about legal and advanced care planning. And at the same time, at the back are some forms. So you can access this online. You can order them for free. You'll see a link on this slide where you get into an order form, and they're sent out by the Northwest Justice Project. It's a very nice folder that you could have a stash of them in your office for free to give out to anybody you come across who has not completed their legal and advanced care planning. So along with that, on the side of this slide, you see another program we have called the Dementia Legal Planning Project or Program. And that is where we have attorneys available, trained throughout the state now. We have some 30-odd pro bono attorneys who have been trained and signed up to provide pro bono services for people who are 60 or older or dementia of any age. They will help people complete their legal planning documents, their powers of attorney for healthcare, finances, and their healthcare directives. They don't do anything more complicated than that. They don't do guardianships, give other legal advice. They're helping people complete these documents. So if you have anybody who has not done their documentation and you want them to get some extra support in doing that, these are both really good resources to have in your toolkit and help people to take that step. So that's super important. All right, I'm going to move on to the next issue that we often find is a challenge for family caregivers, and that is about behaviors. And this is a huge topic, sort of like brain health. This could take a whole hour, so I'm just going to touch briefly on a few really important points. It's really important that families know that that behaviors are one of those things that are sort of on the tipping scale, right? Behaviors tend to be one of those things that push people into an early placement because families don't know how to manage. They don't know how to really understand behaviors and then manage them, right? So remember in that early part of the presentation when I talked about that middle stage, communications going down and behaviors start being on the rise. It's right when it's harder to do things like activities of daily living. We need to be helping families understand that behaviors sometimes are a means of communication, right? Because they can't communicate certain things in other ways. So thinking of the fact that all behavior has meaning is a very important tenet when you're thinking about people who are experiencing dementia behaviors. The sad thing I think about behaviors and families is that families are very alone and they don't know how to manage this, and they very often need somebody like you to bring up the topic of behaviors because they will just sit and live with these behaviors and they're frustrated by them and challenged by them, and they're not understanding that behaviors really, they're a part of the disease. And they arise because there might be something the person needs and they're trying to get their needs met. They could be a sign of stress. It could be something going on physically. It could be something with, the brain that we can't impact. But we have to consider the possibility that it is something that is a need that needs to be addressed. But more importantly, families need to understand that while we recognize they're challenging to figure out, you could help them talk through it and try to think about what might be happening that we need to address for this behavior to not occur or to occur less or to have it bother you less. All of those things would be better outcomes, right? So when you think about behaviors that way, if we go to the next slide, I just want you to think about what can you do to help people with behaviors. The first thing I would suggest is that if you are not particularly comfortable around the issue of dementia behaviors, that you take a little time to do that, particularly if you're seeing it in some of your caseload. And it's not that hard to do. There are some easy free resources to learn a little bit more about dementia behaviors. So we know, one of the things I know, and I provided a couple links for you on this slide. You can just go in. These are a couple of really quick free resources that help you understand a little bit more about dementias and how you can use communication to sort of lessen some of the behaviors, the reactive behaviors that people get, and understanding how to decode behaviors a little bit. So those are both really important little resources. So learn what you can. The other thing I would invite you all to do in your practice is to ask about behaviors when you're talking with somebody with dementia. They're not necessarily going to bring it up. A spouse particularly won't bring up, oh, this is what my wife's doing. She's following me everywhere. She's clinging to me, shadowing me. He's just taking care of his wife, and he's not going to bring that up as a problem, right? It's just what his wife does. So sometimes you need to sort of bring things up. Something like, it's, you could say it's typical for somebody with dementia to have changes in their behavior. I'm wondering what you've noticed. What is your wife doing? Does she ask you repetitive questions? Is there anything that she's doing that make you worried about her safety? Something like, very often people with dementia struggle with showering and not wanting to change their clothes. That's sort of a big thing because those become really complicated, difficult things. So they just resist doing them. They could do them if they had a little bit of support, but they resist doing them. Or you could ask, are there any things that she's doing that's particularly frustrating you at this point? So bringing it up gives them the chance to vent a little bit, to share something with you that you might be able to help them problem solve a little bit. So if you do come across a behavior that you've identified, you can help them to sort of think through what might be precipitating that behavior. If you've all heard about the ABC approach, there's the behavior, there's the activator or the antecedent, and there's the consequence, right? So what was happening before the behavior occurred? Does it always happen at a certain time of the day? Like, are they always worse in the afternoon? When she follows you around, maybe it always happens in the morning when she's just uncomfortable and she needs you to help her, to reassure her that she's going to be okay. So thinking through patterns, thinking through what happens before, and then, you could even ask the question, well, what do you do when she does that? And thinking through, is what he's doing perpetuating it? Is it maybe making it worse? Is there something else that he could do? So thinking through those problem-solving types of questions could really help a family member start to learn, how can I live with this behavior and take care of this person longer? And again, thinking through the fact that, you're not always going to be there. Help them figure out, what resources they could use, like these 2 resources up on the screen. Send them to the Alzheimer's Association. They can have this free learning module that's listed there for free. It's a 45-minute video, helps them understand behaviors, give them resources, help, refer them to support groups or educational webinars that might be offered by the Alzheimer's Association. They can learn a lot from other family members in support groups or these types of webinars. So I encourage you to not only learn a little bit yourself, but help families know that there are resources out there for them and encourage them to use those resources because it can be super helpful. It can really be a game changer for somebody who's trying to live with those behaviors. On the next slide, I do want to share with you another free resource that you guys can access online at our Dementia Action Collaborative site. And these are called caregiver tip sheets. And the first one is called the IDEA strategy. And that's where it walks you through this sort of problem solving approach. So if there's any one that you look at, I encourage you all to look at this one, because it's a way you can have a conversation with families about a behavior that might be happening, sort of identifying the behavior, exploring what might be causing it, like I just mentioned, and then adjusting what you can to maybe make it happen less, have it be less, less of a problem. So these tip sheets, there's 18 different topics. So, there's topics around bathing, around getting lost, resistance to care, like getting dressed or showering, sundowning. And the way they're formatted is they're English on one side, and then the other side, you can get them in Spanish, Japanese, or Chinese. So I would encourage you to take a look at these. Start partly for your own edification to know they're there, but to know if you have people who are experiencing these might be a very good free resource. They can just look at them online. They could print them out and download them. Great resources that you can share. Again, empowering people to look at a problem and give them some resources to help manage them. Okay, on the next slide, I do, before I leave the topic of dementia, I want to mention just a couple other points. Families often get frustrated with the changes in function and behaviors of a person who has dementia. They can sometimes feel like the person is doing it on purpose. Their behaviors, like becoming more clingy, they might be waking them up at night. They might be asking these repetitive questions or comments, and it really is very frustrating sometimes to certain caregivers. So it's really important that we encourage families to remember that dementia impacts the person's brain, and it's going to impact their behaviors. These behaviors are not intentional. The person isn't trying to be difficult. They're just, their brain has some damage to it. They can't figure things out, so they're behaving in certain ways. And that really can help families to understand that when it's the disease that's causing the behaviors, and it's not the person just trying to be difficult. It's not that they're just not listening. At the same time, it's important to empathize and to recognize that it's difficult, right? And it's challenging. And we know you might lose your temper and you might get frustrated sometimes, but let's think about the things we can do to maybe lessen the behavior. And that might make them feel a little more empowered than frustrated. Okay, so if we go to this is my last slide on the behaviors. I just want to share with you, and some of you know this, but I want to review it because it's something that families need to be reminded of, is that there's sort of a typical way that a person with dementia acts, right? Particularly somebody with Alzheimer's, the kind of changes they have over time are gradual, and it happens slowly. But if there's a change in behaviors that's sudden, right? So maybe they're suddenly really depressed or really agitated or suddenly just much more confused than they were 2 days ago. Or they start pinching or hitting or suddenly incontinent. Things like that happen suddenly need to be paid attention to. If you see something that happens suddenly, maybe in a couple days or in the period of a week or so, it's important to have that person talk to the physician or have the family member call a physician. There might be something physical going on. Those of you who've worked in residential settings know, it could be a UTI. Very commonly it is a UTI, but it could be something else, some other type of infection. It could be pain that has gotten worse. Sometimes people have fallen, we don't know it. They might have a fracture, like a hairline fracture. It could be causing pain. It could be an escalation in pain from some other condition. that's causing it. So because we can't necessarily rely on the person with dementia to have connected the dots and report that this certain thing is causing them pain or this certain thing is going on, we need to be vigilant that if there are changes in behavior that are sort of more sudden, that we get them medically assessed. So that's an important thing for families to understand. So I hope that makes sense to you. So I want to review, I want to go back to our case example. If you go to the next slide, we're going to go back to the same case example. So in this case, we've already talked about Mrs. K and how she's changing. We've also talked about Mr. K and how he had been trying to really keep her at home. He's doing more and more things for her because now the dementia is progressing. So this time when you visit, you note that the dishes are piled up in the sink. The house is less tidy than even before. Mrs. K is sleeping in a chair when you get there. Mr. K looks exhausted and reports his wife has been getting up in the middle of the night. What recommendations or services do you think might help this family, this person who's living with dementia and has a caring husband there, but he's not looking so good? So what kind of things might you want to put into place or talk with this person and family about? Why don't you go ahead and throw some things into the chat that might come to your mind? Yes, an outside caregiver to help, somebody to come in-home care provider, some rest, but yeah, whether it's her going to daycare or somebody coming in, the family caregiver program, yes, one of the family caregiver programs all over the state. Maybe consider home care at night, yeah, so that he doesn't have to be the one getting up and helping her, right? Groups to have her visit, yeah, to get her out of the house and have her busy during the day. Counseling if depression is showing, yeah, for the family caregiver, I think you're meaning there. If he's starting to get a little overwhelmed, he might need some counseling himself. Talk to Mr. K about burnout. Yeah. Very often these kind of caregivers just say, I promise to keep her home. And, you have to talk to him about the fact that if he's not there, she's not going to be able to manage, right? So what could we do to help him understand the importance of self-care? Yes. Thank you for bringing that up. He's resistant to putting her away. So being empathetic and talking about the impact of her care on his health might be important. Yes. Yeah. And that's a good way to think about it, Jeff. Thank you for bringing that up. It's, if he wants to keep on caring and wants to keep her at home, he really does need to take care of himself and putting that in a light to him that he can understand. The caregiver should see the primary care. Yes, John, thank you for bringing that up. There are studies that show that there are plenty of caregivers who get very ill. They don't take care of their health. They sometimes die before the person with dementia because they haven't been taking care of their health. Some of the times they might have a heart attack. It's very stressful if you're providing a lot of care over a long time and you have health conditions of your own. So yes, those are all great suggestions. So thinking about the variety of things you could do. I see a question. Are there any memory health screenings you would suggest friends or families do and provide to the PCP? Just friends and family do. Carrie, that's a good question. There have been a lot of things. If you go online and look at caregiver, there's a lot of they're called caregiver quizzes or caregiver stress tests. I don't have them right at the ready, but if you want to send me an email, I can send you a couple of little clips that I have seen in the past about helping a caregiver to think about their own health and what they might be doing to help with their health. Ensuring there's plans in place for the wife should something. Oh, that's a great point, Amanda. Thank you for bringing that up. I really, that's something when I was doing my care management in the nursing home, we would have people, complete a little sort of an emergency file. What does the person need? If something were to happen to the family caregiver, here's a list of all their medications, here's a list of her schedules, here's her doctors, like you would if you were having somebody come into the home to care for anybody. And I like that you brought that up, Amanda, just because it's such a great idea. So add that to your toolkit, and I might consider adding that into here. Thank you for bringing that up, because it is not uncommon that something might happen for the caregiver and somebody else needs to step in. Great ideas. I can see you guys have been at this a while, or at least have this situation. Oh, I also like this comment, looking at alternative living for them both. That could happen. And one thing I always recommend for families is thinking about, if an emergency happens, what would be the place you might choose, right, for the person to go. Not that it will happen. You're not saying I'm going to place her, but having a place in mind, because that can alleviate some of the stress that you've done a little of that investigating ahead of time. These are all great suggestions. Thank you. All right. Well, you guys seem to have a handle on that. The NMMSE, there are a variety of different cognitive tests that might be available. In situations where you're trying to convince a family member to get help, sometimes I really, I think that one of the more important things to think about is that empathetic approach about how do we help him understand the importance to take care of himself. And how do we convince people to take care of themselves? That's a really hard one because they're in that mode of caregiving, right? Janelle says there's screening online for dementia and for Downs. Yeah, there is a lot of information online. Barbara, that's an important point, to keep their friends. One thing we hear a lot about from families is that their friends drop away. They're uncomfortable around the dementia. They don't know what they can do to help. And I think it is important to encourage them to try to maintain their friendships. If they need to have a caregiver come in the home so they can spend, 1 day a week having coffee with their friends, that's really important. And that might be enough to help sustain the caregiver's mood and to help them, be able to keep at this caregiving a little bit longer. So there's a lot of different ways that we can support them. Where can we find a care counselor and support group resources for family? Well, I'm going to be talking about just in a moment. So I think let me go to the next slide because I just wanted to consolidate what all your guys' great suggestions were. So here's just a little reminder of some different services that we might think about helping a family member with. And we might not always think that something like Meals on Wheels will help, for a person with dementia, but if it can relieve the stress on a family care partner of preparing meals, shopping, that could, alleviate some of the stress. Somebody to come in. The Family Caregiver Support Program offers something called housework and errands, where they can just help around the home, running some errands. So it's not necessarily, cleaning the bathroom or whatever, but helping with some of the little tasks to alleviate the burden on the care partner. Consultation and training. Yes, many areas have an RN who could go in, maybe help with medications, maybe help with a variety of other things related to healthcare. Powerful tools, classes on how to be, how to take care of yourself as a caregiver. That's what Powerful Tools for Caregivers is all about. So just thinking about these different types of way you could support a family is super important. And these are available in many communities. So I encourage you to sort of think through this really broadly about how you could help a family care partner. Thank you all for your suggestions. Those were all really great. So let's move to the fourth medication management best practice approach. We touched on this a little bit. I do just want to remind you, that when we're thinking of dementia as that organizing principle of care, really focusing on medication management is important because people do land in the hospital a lot around medication issues. They're taking them too much. They're not taking them enough. They might be taking the wrong things. So medication issues are really big with dementia. And I would just encourage you to, whether it's the person who's living alone and needs some self-reminders or needs some support, just thinking about what does this person need to manage medications safely. I have seen some of the lists in like different assessments of the number of medications people are on, which can be a lot. So we have the opportunity to sort of think through, how could we help with this? Could we find a way to work with the physician, with a pharmacist, to simplify the regimen, to have somebody do a medication review? Are some of these contraindicated? There are some medications people are having that are increasing, say, the chance of dizziness, which might increase the chance of falls. So doing a really good med review on what kind of things the person really does still need, and a way to simplify maybe the medication regimen. Sometimes a pharmacist can help, just creating the bubble packs, creating different ways to do them, or changing a medication from being taken 3 times a day to being taken 1 time a day, right? So anything we can do to think about simplifying the medication regimen so that it can be done well. Those are the things we might want to think about. So if you go to the next slide, I think it's really important that we're thinking about how we can help with that. It's just something that families often don't think about as a way to make things a little bit easier. People with dementia are eventually going to need help with taking their medications. So what do they need? Do they need the reminders? Do they need a person to do it? Do the medications need to be locked up because they might be taking them inappropriately? What kind of things do we need to put into place? And if you're working with a family caregiver, we just need to make sure that the people are taking the right medications, they're taking them at the right time and in the right amount. So trying to simplify the process for them. I've put a resource here for you that you could go onto online if it's helpful to you if you're running into some challenges on managing medicines for people with dementia. And it just gives you a few tips, things that you might be able to use in your conversations or things to share with families themselves. Okay, then on to our fifth balancing independence and safety best practice. And this is really to acknowledge something that gets to the heart of person-centered planning, thinking of the idea, what's important for versus what's important to. So for most people, not all, but for most people, the ability to make choices for themselves is really important, right? But the person with dementia, thinking skills and judgments might have become impaired. So certain behaviors could be unsafe for them or for the family caregiver. And people, I know you have found this, have different comfort levels. There's some families who want to be super protective, others who are okay with allowing some independence. And when does that independence become dangerous? And who is it dangerous for? So thinking through all those things, throughout dementia, there's going to be different considerations for safety. In those early stages, it might be about driving or smoking or leaving the stove on or a risk for financial exploitation, right? In the mid stage, you have things like wandering, self-neglect. They're not eating, they're not taking care of themselves, they're falling, they might be resistant to care. In those later stages, you have the risks of swallowing or choking or falls, or in those later stages, you might have the risk to the family caregivers who are trying to lift them and move them around. There are all these things to be considering, right? So you might be the person who's there to help them think through and help them talk about this sort of balance of independence and safety. People very often are struggling with, the example of having a wife who has dementia managing her own medications. And you might be the person to talk to them. It is important for her to be independent, but can we find a way to do that where you're supervising her medications and you go in each day and encourage her and literally watch what she's taking? So what kind of help needs to be there? Not help that's too much, but help that is enough to keep it safe for that person. So I think a lot of times the role that we can play is to help people think through this and think through alternatives. Very often people get stuck in what they're doing and in one frame of mind and not thinking through the different alternatives. So we can help them think through the fact that there could be medication reminder toolkits or bubble packs or a pharmacist who might be able to do something different. Or there might be some things we can do in the home to decrease some of the risks. Right. So helping somebody by listening and thinking through your whole toolkits that you guys all have in terms of what are some of the things we could put into place to help the person remain as independent as they can at home, but with enough supports so that it is safe. To help you do this, we do have on the next slide, if we go to the next slide, you'll see something called we call it the Dementia Safety Info Kit. And it addresses the 6 issues you see up on the screen, sort of home safety in general that could be given to a family member. It gets to a link on what are the things you can look at, falls prevention, the conversation about driving, which is really difficult in those early stages, wandering, emergency preparedness, and elder abuse and exploitation. So this is a toolkit, again, that you could use for yourself to sort of think about what are all the things I could be thinking about. But it's available online, it's free at our Dementia Action Collaborative website, and it could be shared with families. Here are some resources for you to look at. But again, it could frame your conversation or something that you could present to them. Okay, now I'm going to go to the next slide. And here's something I just want to mention because we have touched on this, but I want to just bring it to fore because I think you guys probably do have people who go in and out from hospital to home and possibly back again. And it's really important because people with dementia do not necessarily do very well with hospitalizations. You've probably noticed that. It can be a very stressful environment. It's out of their routine. It can be noisy. So a lot of times people come back from hospitalizations even more confused than when they came in, because of all those changes, possibly because of whatever their health event made them go to the hospital in the first place, right? So when they're transitioning back and forth, their environment changes, and that's going to also increase their safety risks, right? So we need families to be aware of this, and something they could even be a little bit prepared for. So you might be prepared as somebody working with them to say, wow, when they come out of the hospital, they might need a little extra support. They might be a little unsteady on their feet. They might be a little more confused. Let's see what we can to make the home safer, get the place set up for them when they return home, watching for maybe falls, type things like a little bit of dizziness, maybe having the room set up where it's, very familiar to what they had before, and then paying much more attention in those first few days after they return home. Medications, watching for pain, making sure that they're not, unstable on their feet. So thinking about how can we help people with that, managing not only any new medication regimen, but anything they need to be doing at home. They're going to need extra support with that. And I think a lot of family members, they think, oh, the hospital is going to tell me that, but they give them all these instructions at a point when they're stressed out and they're trying to manage things. They might need help with managing that sort of transition back to home. And there are ways that you as a health home coordinator might be able to help them with that. And I would say, if you go to the next slide, there are some great materials that have been done just on this very issue on hospitalizations. And some of them are preparing for a hospitalization you know is going to happen, say if they're having surgery, things you can do to make that hospitalization a little less stressful. But also, I think, can help prepare a family member thinking about what could happen if it happens in an emergency. What might I be able to do? Having an emergency sack with comfort items available, that you create ahead of time, a list of their medications, little things you can do to have set up ahead of time. Again, it's sort of like what Amanda mentioned earlier with, planning for a time when somebody might need to take care of them. Planning for a hospitalization that might occur can reduce some of that stress. So this is just a tool you could have it for your own edification, ways you can help, or it's something that you could share with families. And then lastly, this is the last topic I want to touch on today, is helping people who are living alone. And I've talked a lot today about working with families because that's what we have to work with in terms of helping people with a best practice. But there are people who are living alone. I recognize you're probably helping a lot of those folks. We've shared a lot of resources already on how you might broach conversations around cognitive impairment, helping them understand the importance that if they want to stay independent, there's certain things that they might be able to do, can do to help themselves be able to do that. Helping them to stay healthier, helping them link up with some social resources in the community where they're going to build their networks. So this handbook that's up on the screen, it's available for free. This might give you some tips. It talks a lot about, it's designed for social service professionals or legal professionals who are working with people who live alone. And it offers some strategies for assessing risk, identifying people who might be able to help in the community, determining decision-making capacity, options for helping the person maintain their independence. And it also talks about ideas for getting help with housekeeping and home maintenance, which we've already talked about today. But it's just another tip if you're working with somebody who lives alone and you just, you're seeking one more idea to help, this kind of resource might be helpful to you. Okay, so going to the next slide. We're just almost at the end, and I just want to review in case you're ever feeling stuck on how to help, to consider these 5 best practices of, early identification. Could we have a conversation and get somebody to move towards diagnosis so they can get the best care? Am I considering all the impacts that dementia might have on their other needs? And if so, what could I do? And then the 3rd best practice, including and supporting care partners as much as we can when they're available, and it's a supportive relationship. The 4th, medication management, just keying into that because that is so important to that person being able to stay healthy and hopefully not have medication mishaps. And then the 5th, being available to help people navigating and understand sort of those safety issues at the different stages and the supports that we can help with to help do the things that are important to the person. And help them do the kind of things that they want. So just keeping in mind these best practices might help you as you're working with people with dementia. And then on the next slide, just what we call dementia capability recommendations and referrals, just keeping these in mind at any time you go out and visit with folks. Again, if they have cognitive impairment and no medical assessment, explain why it's important, the value of diagnosis, and recommend or suggest that they make an appointment with a healthcare provider. I always suggest referring people to the Alzheimer's Association, or there's the Dementia Support Northwest, which serves Whatcom County. The Alzheimer's Association has a 24/7 line where people can call about a behavior, about a legal issue, about getting a diagnosis. That's an additional source of support. And I would encourage you to have that in your handbook and refer people to the Alzheimer's Association, because they have support groups. They have webinars. They can just help people understand dementia. And that is not a small thing, to help family members and people who are living with dementia to get educated so they can get the help they need. And then the third thing is always to keep in mind those community services, whether it's through an area agency on aging or other community services about. Link people up with services. We can't be there for people all the time, and we need to build their support networks. So thinking about those different services people can use. And then my very last slide is just a little cheat sheet for you. And this is just something, these are things at each stage, early, mid, and late, things you might consider referring people to if you get stuck, thinking about the best practices, thinking about the things you can do, whether it's for the person living with dementia or you see a little CG caregiver here, things to help the caregiver like housework and errands, or powerful tools for caregiving, support groups, dementia consultation, which is available in many areas of the state. Just the things that you can do. So just a little cheat sheet for you. Okay, and I'm going to end there because I do want to have a few minutes for questions. I realize we went almost up to the hour. So if there's any questions, feel free to bring them up, or you can email me. Carrie, did we have any questions in the Q&A?
No, I'm not seeing any questions pop in the Q&A.
Okay.
I tried to keep up with you, Lynn, and if I could, I'd throw some links in the chat.
I had planned to do it myself, but it's just a little complicated with getting everything in there. So the links should be live on the slides. If you happen to come across any that aren't, let me know and I will get you the information. Happy to help. And they're all, I've sort of tried to summarize them throughout and then at the end.
Looks like there's a comment in the chat. I've noticed that the long-term care program will sometimes go after someone's assets after they are deceased, but it is unclear how or how much they do. This has stopped unpaid family caregivers from moving forward with getting some outside help. This isn't a question, more just information I thought you may find valuable. Yeah, that looks like a good question for Office of Financial Recovery.
Yeah, and I would say there are programs, in Medicaid, they do have the right to come after a home, but not if, there's certain provisions that can be put into place. So I would encourage people to ask about that. You can go to the Northwest Justice Project. They have some really good information on that. And so certain programs like the Macintosh program, if you're familiar with that program, that was set up with a provision that, people would not have to, they couldn't come after your home. So I would suggest, looking at the Northwest Justice Project, because there are some situations where that is not true. And, I'm not a legal expert on that kind of stuff, but I have heard those things, and I would encourage you to look into those facts when somebody says that, because there are different ways to navigate financial planning, and there are different caveats with different programs. So thanks for bringing that up. Great. Well, thank you for your comments, and thank you for your attention today. It's a huge issue. I wish you well with everything you do. Thank you for what you do for this group of people. And again, I'm here for questions if you can't find a resource. So thanks very much.
Thanks, Lynn.
Thank you, Lynn, and thank you everybody for attending today. That was a great presentation, very robust and a lot of great information. Just so you know, if you're still on, the slideshow will be sent out to you hopefully before the end of the day. And hopefully within the next couple of days, you will be able to find this webinar in its entirety on the DSHS website under ongoing training. So thank you all so much again. Thank you so much, Lynn and Carrie, for you guys helping and facilitating this. Y'all have a great rest of your day. Bye now.
Thanks, Anthony and Carrie. Bye.